Uh, Greetings from NITRD. A very warm welcome to our esteemed guests and colleagues for 8th NITRD Pediatric TB Eco Clinic, organized in collaboration with the Regional Pediatric Centers of Excellence for Tuberculosis. Today, we completed our first edition of this Pediatric Eco Clinic session, and which was started in the month of May under the leadership of our then director, Dr. Sangeeta Sharma ma'am, and it was a great success, which these sessions were being joined by all the stalwarts in the pediatric pulmonology from across the country. And with this great success of the first edition, we are moving forward with the second edition of our pediatric TB Eco Clinics, and which will be inaugurated by senior consultant and Dr. Sangeeta Sharma ma'am in the Department of Pediatrics. She's also the head of the Center of Excellence at NITRD in Pediatrics. So we all are aware that the primary goal of all these clinics is to disseminate the latest pediatric TB guidelines across the country and mainly to the peripheral levels. So it is my privilege to extend my heartfelt greetings to our honored guest, Dr. Urvashi B. Singh ma'am. She is Deputy Director General, and her team, as well as the directors and teams from NIIT, NTI, state TB officers, directors of STDCs, and faculty members from medical colleges, district TB officers, medical officers, and TB pediatric experts, and everyone who is joining today's session. So, the highlight of today's clinic is we'll be having a special session on newer DRTB regimens in children. Available evidence from by our guest of honor, Dr. Jennifer Furin, who is a consultant in infectious disease at Harvard Medical School, Boston. So, without any undue delay, I'll introduce the faculty from NITRD. To my right is Dr. Sangeeta Sharma ma'am. She was former director of NITRD, consultant pediatrics, and in charge of the National Center of Excellence for Pediatric TB and DRTB at NITRD. To my extreme right is Dr. Alok Yadav, chief medical officer, and right is Dr. Dhulika Dhingra, specialist in pediatrics at NITRD. And I am Dr. Saroj Meena, chest specialist at NITRD. It's my honor to moderate today's clinic. So I would request Dr. Sangeeta Sharma ma'am for opening the session for today's clinic. Ma'am, over to you.
Thank you, Suroj. You've just narrated the journey. Pediatric Eco was one of my dreams to start this on the Zoom platform to disseminate the kind of support I received from all my national colleagues. That is so heartwarming, and I thank each one of them. And the purpose is solely to interact. And without wasting more time, I will now hand over to Dr. Urvashi, because she is another dynamic lady who has taken over the control of our National TB Elimination Program. Dr. Urvashi.
Good afternoon, everyone. Thank you for the kind words, Dr. Sangeeta, and very, kudos to you, Dr. Sangeeta, and your team for doing this exercise for the benefit of all the experts across the country. So it is always a learning experience because you are always able to invite the top experts in pediatric TB, and I've seen through the last few eco clinics how each of them are able to contribute and resolve doubts, bring in guidelines where they matter, and make a difference to all the pediatricians across the country. So it is actually very heartening, your effort, the support of NITRD in running these clinics regularly for the sake of, bettering the treatment of children, strengthening the knowledge of all the pediatricians to follow the right guidelines, be it international guidelines, be it national guidelines, and actually deliberate on difficult cases, small issues explained scientifically so that no doubts remain. So it's like a continuing medical education And let me applaud your efforts and your team's efforts and your institute's effort. So thank you again, and thanks to all the concerned pediatricians, STOs, DTOs, whosoever has been able to join today. I'm sure they must be gaining from the past experience with the difficult to treat TB clinics, the pediatric TB eco clinics, that they're here today again. And let us proceed with the day's case. Thank you.
Thank you, ma'am, for your continued guidance and motivation. Your presence is a source of inspiration for all of us. So, without undue delay, we would be moving ahead with the case presentation, which will be presented by from the Department of Pediatrics, NITRD, and Dr. Alok Yadav, who is also the case expert for today's case, will lead the presentation. Over to you, Dr. Alok.
Thank you very much, Dr. Saros. And I am sharing my case. So, good afternoon, everyone. So, today's case is a case of 6-year-old female resident of district Palwal, Haryana. The information was given by the mother and the aunt presenting in our institute in January 2023 with the complaints of cough with expectoration from last 5 months, fever on and off from 4 months, chest pain from 3 months, loss of weight and loss of appetite, near about 10 kg in past 4 months, shortness of breath and hemoptysis, 2-3 episode in last 15 days. So history of past illness, present illness, cough was associated with the expectoration for 5 months and there is no diurnal variations. Fever, initially the fever is low grade, later become high grade, documented up to 101 from last 4 months and sometime associated with the chills. Chest pain, dull aching on both sides of chest, increasing with respiration, loss of weight and loss of appetite. Shortness of breath is progressive. MMRC grade 2 to grade 3 in 3 months, increasing with exertion. Hemoptysis 2-3 episodes around half teaspoon of fresh blood in last 1 week. History of past illness, 1.5 year back, patient has similar complaint of cough with expectoration from last 2 months, loss of appetite, fever for more than 1 month, significant weight loss from 1 month. Patient visited to the nearest hospital. TB workup was done. At that time, investigations was sent. In gastric aspirate sample, smear was found 1 positive for AFB. CBNAT was done, which was found MTB detected. Low and RIF resistance was detected at that time. So this is the chest X-ray at that time when the patient was detected smear positive. On the basis of the CBNAT report, shorter regimen was started in October 2021. Regimen which was given at that time is 4 to 6 months of levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose INH, ethionamide, amikacin, and 5 months of levofloxacin, clofazimine, pyrazinamide, and ethambutol. Drug doses of amikacin was 15 to 20 milligram, levofloxacin 15 to 20, clofazimine is 2 to 5 milligram per kg body weight, ethionamide is 15 to 20 milligram, high dose INH is 50 to 20, pyrazinamide 30 to 40, and ethionamide is 15 to 20 milligram. At that time, the weight of the child is 12 kg, so doses dose was given is 250 milligram amikacin, 250 levofloxacin, clofazimine 50, ethionamide 200, INH 250, pyrazinamide 400, and ethionamide 250. And the final outcome, which was declared after 9 months in July 2022, was good. So at that time, no smear and culture was done on follow-up samples. Birth history of the child was born full term, delivery by normal vaginal delivery in hospital. Cried immediate after birth. Weight is 2.6 kg. No NICU history. Developmental history is as per the appropriate age. Immunization was done as per national immunization schedule. BCG was given at the time of birth. No comorbid T was present, asthma or diabetes. Family history, there is family history of TB contact is present. Grandfather passed 3 years back due to prolonged fever, cough and episode of hemoptysis. He was on ATT, including some injectable drug as told by the attendant, but detailed record was not available with the patient. Father has a good health, work as a guard, Mother is maid servant, works in the farmhouse and potty. Two siblings, all has good health, social and environmental status as per the Kupasami scale lied under lower middle economic group. In the examination, child has pallor but no icterus cyanosis, clubbing, pedal edema, or generalized lymphadenopathy was not present at that time. Vital was good, pulse stable 108, BP was 90 by 50 in spine position, respiratory rate 26, and saturation was 99 at room air. Systemic examination as in respiration, basically S1, S2 was not. Cardiovascular examination was normal. Respiratory system was air entry was equal. No respiratory distress. No chest asymmetry. Chest movement bilateral equal, but crepitations was present. No Rankine was present. Abdomen examination, liver is 2 centimeter below left costal margin. Spleen is 1 centimeter below left costal margin. CNS, child was well oriented to time place person. No focal deficit or any other abnormality was found during CNS examination. Anthropometry, during weight of the child is 17 kg and height of the child is 113 centimeter. So it lie between the 10th centile to 15th centile in height and weight 3rd centile to 10th centile. BMI is 12.9 kg per meter square. Child comes under weight category. So child was presented at the time of NITID with cough, fever, chest pain, loss of weight, loss of appetite, and shortness of breath, as we told in the ST. Chest X-ray was done at that time in January 2023. At that time, the investigation which we done, we found hemoglobin is 8 milligram, TLC 9000, DLC neutrophil 60%, lymphocyte 30, monocyte 10, eosinophil 3, platelet count is 2.5. So microbiologically, investigation was sent at that time. CBNet, in the CBNet report, MTB was detected, RIF resistance was detected. First line LPA was sent. In the first line LPA, smear also found 2 positive. First line LPA, in the first line LPA, rifampicin isoniazid high and low level resistance was found. CATG and INS mutation both was present. In second line LPA, fluoroquinolones, levofloxacin, moxifloxacin, high dose resistance is present. Gyre present, wild type absent, and 3C mutation was present. Second line injectables are sensitive in the second line LPA reports. So on these reports, the diagnosis we made is pre-XDR pulmonary tuberculosis. So pre-treatment evaluation was done. So in the pre-treatment evaluation, hemoglobin is 8.8. We do the blood transfusion and repeated HB was 11.1 gram. TLC is 9000, DLC is neutrophil 60%, lymphocyte 30, monocyte 10, and eosinophil 3. Platelet is 2.5. LFT, KFT is normal. TSH is also normal. Serum calcium is 7.8 milligram. So we did the calcium correction by giving the calcium gluconate. Electrolyte, sodium, potassium, and magnesium all are in normal limits. Amylase, lipase are also normal. HIV serology was negative, and RVS is 90, and QT ECG QTC interval is 448 at that time. So the diagnosis bilateral extensive pre-XDR pulmonary tuberculosis. So we plan all oral longer regimen which as per the NTP regimen. So the bilateral extensive pre-XDR fluoroquinolone low and high level resistance. So as per the guidelines, we generally take 3 drug in group A and 2 drug in group B if the drugs are sensitive, and to make the regimen of 5 drugs. But in this case, the levofloxacin and moxifloxacin was found resistance. So we take 2 drug from group A and 2 drug from group B and 1 drug from group C. So we made the regimen bedaquiline, linezolid, clofazimine, cycloserine, and delamanid. So final regimen is bedaquiline, linezolid, clofazimine, cycloserine, delamanid for 18 to 21. The doses is the child weight is 17 kg. So doses as per the NTP is bedaquiline 400 milligram for 2 weeks, then 3 times per week, linezolid 300, clofazimine 50, cycloserine 250, and delamanid 50 milligram 2 times. So when we start these regimen, we do the ECG sequence. Primarily baseline ECG was normal at that time. However, after introduction of the drug, QTC interval raised from 480 to 490 with the first dose. So due to QT prolongation, cardiotoxic drug in this regime, just like bedaquiline, clofazimine, and delamanid was stopped, and we sent the repeat electrolyte samples to recheck, in which we found calcium was 8.9, serum potassium is 3, magnesium is 2.2. So we repeat corrected these electrolyte calcium and potassium. After that, we reintroduce the drug bedaquiline after 5 days. On the sixth day, the EC bar done, which is 430 millisecond, and after third day, we added another drug of clofazimine on means on 9th day, and on fourth day we add another drug is delamanid on this regimen. So later on, we do the sequential ECG in which the QTC interval was found normal. So later on, the culture reports in the follow-up, we send the culture reports. On the culture report, the third month culture onward reports, smear and culture all are found negatives. Patient improved clinically, radiologically, and subsequent culture smear after 3 months was found negatives. So this case just want to showcase things are wrong in this case basically. So as the case is a close contact in the family, as grandfather died due to TB treatment, so the children who are in close contact with the family member who died due to TB treatment comes under the probable DRTB cases initially. Initially, the CBNet was done, but sample was not sent for the first line and second line LPA report and liquid culture DST. So probably we at that time we missed the fluoroquinolone resistance in this patient. Chest X-ray, initially the chest X-ray done also show the multi-lobe involvement in this X-ray film. So this comes under extensive parenchymal involvement. So initially this child is not eligible for the shorter DRTB regimen which was started initially. Also the follow-up cultures was not advised in due course of the treatment outcome, but outcome was declared as a CORD. So no record of actologically conversion was present in the records. So regarding the probable MDR among children with sign and symptoms of active TB who in addition have the following risk factor: close contact with the known case of DRTB, close contact with a person who died while on TB treatment, close contact with a person who failed TB treatment, and non-responding or failure of the first line regimen previous treated with second line medication. So these are probable MDR in the children's. So basically, this child lie in the close contact with a person who died while on TB treatment. So this comes under the probable MDR case. So the child was prescribed the oral MDR TB regimen, but as per the guidelines, if there is history of exposure of previous treatment with second line medications which are involved in the shorter regimen, just like bedaquiline, clofazimine, ethionamide, and levofloxacin for more than 1 month unless susceptibility to these regimens is confirmed. So these and MDR rifampicin resistance with fluoroquinolone resistance is not detected, and MDR rifampicin resistance with H resistance detected, inferred based on INH mutation only or based on CATG mutation. No extensive TB disease, no severe pulmonary TB. Children 5 to 18 year of age and weight greater than 15 kg by consultation with the pediatrics. These are inclusive criteria of the MDR. So this child have a extensive form of TB disease, but the oral shorter regimen was prescribed at that time. And as per the disease severity in the children's, there are two categories: severe disease and non-severe disease. In the non-severe disease is peripheral, only the peripheral TB lymph node are present, या intrathoracic lymph node without airway obstruction, uncomplicated TB pleural effusion, without empyema pneumothorax, non-cavitary disease confined to one lobe of the lung and without a miliary pattern, and severe form of the TB in children present of cavity or bilateral disease on chest X-ray. So this child have bilateral disease basically. So the case summary is that a 6-year-old female, all treated case of pulmonary TB, had received shorter DRTB regimen 1.5 year back, there is a history of contact, suspected MDR contact expired, now presented to NITD with history of recurrence of on and off fever, productive cough, weight loss, and hemoptysis. All oral longer regimen BLPVS was started. Patient improved clinically, radiologically, and subsequent culture 3 months onward was found negative. Patient completed treatment as per the national policy and declared cured. So this is the case summary.
Thank you so much, Dr. Alok. You have picked up a very important case, and these are the cases which we get to see in the field condition day-to-day basis. And you've highlighted important points of how to choose a shorter MDR regimen. So the house is open for the questions. If against
Can I
that,
come in,
yes,
Dr.
ma'am.
Meena?
Yes, ma'am. Please.
So, could you kindly share with us the timeline of the investigations received, the results received, and the timeline of treatment initiated and switched, please?
So the patient was taken shorter MDR regimens from December 2021 to October 2022, and thereafter she presented to NITR in January 2023, and within a
Where
month.
was the shorter regimen started? Where was it started?
Ma'am, shorter regimen was started in October 2021.
Where?
Where in the Haryana, in the Haryana Palwal districts.
And they started shorter regimen based only on the CBNAT report.
Yes,
Why
ma'am.
was the LPA not?
Yeah, that is precisely the reason, Dr. Urvashi, I asked him to present this case. This case, if you can show the
Dr. Sangeeta, we have discussed this in one earlier case also, where I think it was difficult to treat TB clinic by Dr. Singla, or possibly by you, I'm forgetting. Again, in the field, LPA report was not asked for or not
exactly.
done.
This is one of the
It lost so
reason,
much time. Yeah.
So, because for the information of the house, that whenever the gastric aspirate or the respiratory specimen is smear positive, and this is the time after NAT, immediately the first and the second line LPA should be sent. Once rifampicin resistance is there, then all the more for second line LPA, because you need to rule out, because over here itself the child could have been pre-XDR, but nobody in the field sent the first and second line LPA, but the treatment
First
was
line
started,
also, Dr. Sangeeta, because to
was not
start
sent.
a shorter
Yes.
regimen.
Yes, they started shorter because the inclusion criteria of shorter itself, we have to rule out both INHA as well as CAT-G resistance. Because if both are present, then the child would have been ineligible. So none of these reports is available. And even the past history of the grandfather dying due to tuberculosis, even the DST of the contact should have been taken into account. So there are so many learning points in this case. And now, even looking at this chest X-ray, it shows more than one lobe involvement on the right side, and even in the left side, you can see that there is hilar lymphadenopathy, as well as the middle segment. There are some infiltrations there. So this, in any way, is not non-sphere pulmonary tuberculosis, because to label as a non-sphere or not extensive pulmonary tuberculosis in children, there should be no cavities, and the involvement should not be more than one lobe. But over here, as you can see, so all the criteria have been missed in this case. And then so the diagnosis missed, the history missed, that grandfather, the chest X-ray is not eligible for shorter. Then coming to the microbiological investigations, the gastric aspirate, once it's coming for smear positive, immediately the first and the second line LPA should have been sent, because to fit into the criteria of shorter, I mean, this child as such also does not fit. But mind you, had the chest X-ray showed only one lobe involvement, even then, without the first and second line LPA, you cannot start the shorter MDR TB regimen. Now, aage chalo. Now, so wrongly this was started. And next is then the other thing
And
is
you raised that the grandfather was ill,
exactly,
and
and he
after the
died.
diagnosis of this child, was the family even investigated for any active TB? Just because they say the child is healthy, the older two brothers are healthy, doesn't
No,
mean that they will
yeah,
not be housing any
yes,
latent disease. I mean, it
yes,
is it should be
yeah.
ruled out.
Yeah, that is a
And
very, very important point, which Dr.
disease to
Urvashi,
be
you are
ruled out, TPT to
exactly.
be given when it can
Exactly,
be given.
exactly, exactly. So, because we have just limited to this case, but the point which you have raised that we have already taken care of. Once the child came to us, we examined the other two siblings, and they are healthy, and they are also started on 6 months of levoflox cannot be given over here because this is a pre-XTR TB. So the only thing is these contexts they are on a regular follow-up. So the regimens of TPT also should be taken into account. If you want, I can just for the information of the house because this is a MDR TB case. For MDR TB, we give 6 months of levoflox, but this is now a pre-XDR where the resistance is also to the levoflox as well as I think moxiflox also high level resistance also. So both those drugs are also so you cannot give levoflox, but if Moxie had been sensitive, then we could have given Moxie. But over here, since both the drugs, Moxie as well as levoflox, are showing resistance, so the context, the family contexts are being followed up regularly. And as a follow-up for the context, we do a 6 monthly follow-up, at least till 2 years of the treatment completion of the drug sensitive of this case. So even show about the monitoring. Next, now even if you look at the monitoring, because this child. Next,
Sangeeta, can I just make one more
yes,
suggestion?
please, yes,
You,
please.
you have taken the pains and examined the patients. That is
Yeah,
very kind of you. That is what the field people should also be doing. But also in the field, they should be ensuring X-rays, not only of the children contacts, but of the rest of the family as
yes,
well.
yes, yes,
So I would urge everybody to make sure that every contact is subjected to an X-ray, a physical examination, ruled out active TB, and then if there is no active TB, then give TPT, please.
exactly. So very आगे चलो एक मिनट next दिखाओ एक मिनट. The other thing which I want to highlight over here in the case discussion is the treatment, the follow-up. The follow-up should have been done. नहीं यहाँ नहीं इसे easily लोग का ही केस दिखाइए बिकॉज उन्होंने उसको बिना फॉलो अप किए उसको क्योर्ड डिक्लेयर कर दिया. दिस इज अनदर थिंग विच वेंट रॉन्ग. Neither because there is a monitoring algorithm which I think Dr. Dulika you are taking that. Yeah, she will be presenting that monitoring algorithm for the information of the house, be it shorter MDR-TB regimen, be it longer DRTB regimen. There is a proper monitoring algorithm where we monitor them clinically, radiologically, as well as microbiologically. But over here, as per the records, no record was available for the monitoring. So, Dr. Dhulika, now I ask you to please present for the information of the house how this child should have been monitored.
Yes.
So, any questions from the house till now? Anybody wants to ask any question? Any questions? Okay.
So you can go ahead with it.
Yes. So monitoring.
Like we have discussed, monitoring is extremely important in DRTB patients, whether they are on the shorter regimen or the longer regimen. So in shorter regimen, whenever we have patients, clinical, microbiological and radiological monitoring is what we are supposed to do. In shorter regimen, clinical monitoring is done at baseline, then monthly in the intensive phase, and then quarterly. With regard to the microbiological monitoring in shorter regimens, smear microscopy and culture has to be done at the baseline, and then 3 months, completion of third month onwards.
and the DST is seen at the baseline, according to which we plan our regimen, and then at the end of third month, and then at the end of therapy. Radiological monitoring may be done at the baseline, at the end of 3 months, and then at the end of treatment.
Or as and when required.
Or as and when required. Along with it, in these clinical visits, depending upon the drugs that have been used, LFT, KFT, TSH, and ECG may also be done depending upon the drugs that the patient is on. In case of longer regimen, as we see, again, we do the monitoring based on the clinical, microbiological, and radiological basis. In the intensive phase, the patient has to be monitored every month in the intensive phase and then quarterly in the continuation phase. For the microbiological monitoring, we do it at the baseline and then from third month onwards, then monthly up till 6 months, and thereafter quarterly. And similarly, the radiological improvement also has to be documented first at the baseline and then at the end of 6 months and then at the end of the therapy. This is how we monitor these patients. Further, while based on the monitoring, we also define the treatment outcomes. The treatment outcomes are classified as interim and or as final. So in the interim outcome, we would say that the patient has bacteriological conversion after bacteriological confirmation, which is done at the baseline. At least 2 consecutive cultures are found to be negative. Then we say that there is bacteriological conversion. However, when do we say there is bacteriological reversion? If at least 2 consecutive cultures or smears that were taken on 2 different occasions, at least 7 days apart, are found to be positive. In the final outcome, a patient is said to have failed treatment whose regimen needs to be terminated or has to be shifted permanently to a new regimen or an option. A patient is said to be cured when a pulmonary TB patient who has been bacteriologically confirmed at the beginning of the treatment has completed treatment as per the national policy with evidence of bacteriological response and there is no evidence of failing of treatment. A patient is said to have completed his treatment if he has completed the treatment as per the national policy, but the definition does not meet the criteria for cure or treatment failed. A patient is said to have died if he dies before starting of treatment or while he was on treatment. A patient is said to be lost to follow-up if a patient either did not start the treatment or whose treatment was interrupted for 2 consecutive months or more. And a patient is classified as not evaluated for whom no treatment outcome was assigned. So this is how we monitor and this is how we classify the outcomes of DRTB patients.
So now, Dr. Dhulika, I want to ask you, in children, because you won't be able to get once the child starts to improve, as you said, it is clinical, radiological and microbiological tests which go hand in hand. So as the child improves, now the sputum production goes down. And sputum is difficult to collect in children. So, what would you advise for them as a clinician?
Ma'am, we all know that in children, the respiratory sample is difficult to collect. We can call the child for follow-up for gastric aspirates that we can collect. We can also try for an induced sputum sample in these children for where we nebulize them with hypertonic saline and bronchodilator, and thereafter with chest physiotherapy, we can collect an induced sputum sample. So this is how we can, for this, of course, the patient also needs to be counseled and we can collect the respiratory sample.
So there's another thing for the information of the house. Now, as under the program, evidence and data is emerging where now non-respiratory samples like stool as well as urine. In fact, Dr. Urvashi and I did a study together where she did the urinary expert. Dr. Urvashi, you would like to convey to the house if you're there? Madam is there.
Andres, we can take the question.
Yeah. Dr. Urvashi?
Yeah. So,
Can you just tell us about that study because that is quite
the idea for using urine and expert on urine came from circulating DNA in cancer studies. So, though what we did was in retrospective samples and published last year, we found the sensitivity to be pretty good. So the idea is pretty simple: either macrophages, which are laden with mycobacteria, or the free DNA can be picked up in the urine. So the gene expert tends to only pick up the intracellular DNA because it filters out the extracellular sample. What we detected, gene expert detected the DNA present in the urine, and it was quite useful. We used stored samples, and we lost the sensitivity because of storage, but it could be tried in. So this is not the program recommendation, let me acknowledge. This is a research study where we found it useful. Till such time it reaches the recommendation stage, you could use it based on the research study. Also, urine lamb we published in the year 2019 in children with intrathoracic TB. So whether they had parenchymal TB or they had mediastinal TB. So the mediastinal TB, you're all aware. Again, this is published, I think, 2 years, 2020, 21, we published this, 21 or 22, where we found urine lamb to be more sensitive than gene expert, because you're aware, unless the mediastinal TB is accompanied by a parenchymal involvement, no bacterial DNA will be present in respiratory samples. If the respiratory samples, that is why we say gene expert in respiratory samples from children and small children may not have as good a sensitivity as it has in older or adult population. Because in adults, there'll be cavity formation and there'll be communication of the cavities, and the DNA and the mycobacteria will be present in the respiratory samples, which is not always true in the case of children. So both urine lamb, urine gene expert, stool gene expert, or TrueNat. So it does not only have to be gene expert. TrueNat will also show the similar results. So these are just thoughts, but none of the nucleic acid based tests can be used as a prognostic test. So these should not be used as prognostication markers because the DNA can be present for a long time, and presence of DNA does not mark live bacteria. It is good for diagnosis, but not for prognosis. For prognosis, we should rely on cultures, which again, on treatment, are difficult to grow. Like was found in this child, the cultures did not grow, and which is understood also, the organism is responding. Now, let me also add another angle to this. Sometimes the organism, under drug pressure, under the pressure of antitubercular agents, would go into a stage that's called viable but not cultivable, VBNC stage, and hence the culture will not grow, but the organism may not be responding completely. So one has to be careful during treatment. Under antibiotic pressure, one would understand why the organism will not grow, but during treatment, if the culture is negative, you cannot take it as signature of, you cannot actually call it culture negative. It's only when treatment is stopped and the culture is negative in the follow-up, then you can be sure that the cure is there. Hence, it should always be post-treatment follow-up is another thing which a lot of us are not really following carefully. All patients after completion should be asked to follow up at least for 2 years, so that the relapse, you're all aware, happens in the first 2 years. It is best to call the patients for follow-up so the relapses can be picked up early and the right treatment offered again. Thank you.
So thank you, Dr. Urvashi. That was really good insights and good information because you are the stalwart in microbiology, and these words of wisdom, they really help us. Now we have a few questions. I think Dr.
Yes, ma'am. There's a hand raised in the audience. Dr. Mohammed, you want to ask? Yes, sir, please.
Thank you. Thank you. So I wanted to ask, whenever the primary case is a resistant case, this case is a pre-XDR. Okay, when the grandfather is having the resistance, what TPT should be recommended for the children? TB preventive therapy.
As I said, for TPT in children, now we have TPT available for both drug sensitive as well as drug resistant TB. Even the drug sensitive regimens have now been expanded. And initially, we were just 6 months of INH, 10 milligram per kilogram body weight to be given daily. But now we have 3 HP. That regimen is open for children more than 2 years. But now, as per WHO recent update, they say data is available for the safety of rifampicin even for children less than 2 years of age. In fact, they have even given the dosage schedule. Now, the other regimen, the third regimen, that is and this 3 HP is a weekly regimen, that is INH and rifampicin to be given weekly, total 12 doses. So it takes 3 months for the regimen to be completed. And coming to the last drug sensitive regimen, which the program will be soon rolling out again, that is for emergent situations. That means when there is an emergency. That means if you have a cancer patient and you want to start the chemotherapy, or you want to start long-term steroids, or the child or the adult is on any immunosuppressive, or for organ transplants. So these are those patients, the context where we give the 1 HP, and this is to be given daily for 1 month. Now these are the drug sensitive regimens, the 3 regimens. Now coming to the drug resistance, if you have INH resistance, then you have the 4 months of rifampicin to be given daily. Now, for MDR or RR-TB context, we have the 6 months of levoflox with a modification which is allowed, that you can shift to moxiflox if levoflox is resistant, but moxiflox is sensitive. So 6 months, and this is also a daily regimen. But for cases of pre-XDR and XDR, till now there is no regimen which is defined. So what we have to take care is to treat the source, and that source should follow the cough hygienes as well as the airway exercises, etc. That means the airway control should be there, and all the other precautions should be taken. But no regimen of TPT is available for pre-XDR and XDR at present. Next
Thank you, sir.
question.
Ma'am, there's a question in the chat box which it's been asked that the DRTB results of first line LP and the second line LP are mostly not available at the time of diagnosis of the patient. So how to go about with this patient because there's a delay in getting the results.
Yeah. So I'll be discussing this later also, but to answer this question right now, there are some criteria on the history as well as clinical examination, the chest X-ray, in which we can decide. But to start the shorter MDR TB regimen, we need at least rifampicin resistance and INH. INH you can start if either there is CAG or INHA resistance, but not both. And FQ resistance. So these, they need to be there. But suppose in the beginning they are not there, and you want to start the child on the regimen, and the source is sensitive, there is no INH resistance, or there is no FQ resistance, and there is no history of use of second line drugs which are used in this regimen for more than 1 month. And the chest X-ray, as we have defined, that is what non-extensive pulmonary tuberculosis. That means there should be no cavities, as well as there should be only one lobe involvement. And if there's some hilar lymph node, they should not be causing any compression. And if there is a pleural effusion, it should not be complicated. So these are the clinical criteria. And if there is extrapulmonary TB, the only extrapulmonary TB in children which comes in the category of non-sphere is peripheral lymph node. Rest all are sphere forms of extrapulmonary TB. So I hope I answered this question now.
Yes.
Any other questions?
So I think there was some confusion created. Somebody is asking whether MDR TB patients by the WHO?
For MDR, it is yes, but for pre-XDR and XDR, it is no. Because pre-XDR means that there is already resistance to FQ. So there is no use of giving FQ for TPT.
Yes, I think just to add on, and we should always rule out the FQ resistance before even giving the
Exactly.
prophylaxis to the
Exactly.
patients. Any more questions from the audience? You're done with it.
So any more questions? So now I think we'll sum up our case. So the learning lessons, yeah.
Yeah. So from this case, we have some take-home message we should all keep in mind while treating these MDR cases, whether it's children or in adults both. So second line LPA reports is must before we start the patient on shorter or longer MDR regimen. If we have to start, like ma'am just said, if we need to start the treatment at the moment, then we should not forget to trace these reports, and at the earliest, if changes are need to be made, they should be accommodated.
So I had initially asked what was the timeline of availability of reports. Does anybody have that? I basically want to see what was the delay in the LPA report.
No, ये नहीं तो डिले कहाँ से आएगी? मतलब उन्होंने प्राइवेट लैब प्राइवेट
वहाँ तो पेरिफेरी में तो थी नहीं, बट आपके यहाँ तो आई डॉक्टर साहब.
हाँ हाँ हमारे यहाँ तो है
किया
I
मैम
would like to know what timeline.
हमारे तो
usually 1 week's
No, no,
time.
for this patient.
within a week
No,
within a week of diagnosis the child was started on treatment.
So, Dr. Sangeeta, let me tell you, the LPA does not take 1 week.
Yeah,
It
I
takes
know
2
that.
days.
It takes 2 days. Yeah,
So
we have
everybody needs to tighten their belt and give the
exactly
report 2 days.
exactly
It means a child's life.
बिल्कुल
The lab cannot be slack.
exactly.
I
So
hope
we
that
have
message gets through to all lab people. Do not risk a person's life.
yeah we have Dr. Ritu here with us. I can see her and she is in charge of our LPA lab. So
But I
Ritu,
would appreciate if the lab send the report in 2 days time, please.
yeah. So Ritu, you be careful. We are under strict monitoring 2 days.
Yes, ma'am.
So apart from the microbiological confirmation, the reports, we should also look into the severity of the disease by looking into the X-ray, by looking into the dissemination of the disease. So another message is the detailed contact history, including the drug history of the contact, must be taken before we start these patient on shorter MDR regimen. And yes, monitoring is very important. It should never be forgotten. As per our NTP guidelines, our PMDT guidelines, these patients should be regularly monitored after putting on shorter or a longer MDR TB regimens, which helps us to intervene at the earliest in the favor of the patient's outcome. And TPT, like as ma'am has already said, should be given, but after ruling out fluoroquinolone resistance. So these are few take-home points from the today's case, and if we keep them into our minds, I think we can better increase our patient outcome in a positive manner. So next session we will be having is from our guest of honor, but we are waiting for her to join. And
I'd like to sum up, the regarding what lessons we have learned. If you can just, So no, we have two kind of patients. Those where the history of ATT is there for more than 1 month. That means the child is not improving. That is clinical radiological deterioration, or there is microbiological deterioration, or the child, as we have seen, had some interim conversion or reverts back. So any reversion after conversion or a relapse. So these are those patients where we have to presume it could be a DRTB, and then if the child has history of prior ATT at any time in life, not more than 1 month, that is taken as a new case. But in these children, those who are either HIV positive or they have a contact, as we have seen in this case, any contact, DRTB contact, or a death in the family, or a death where you do not know the DST. So these cases. Next, is this it? Yeah. So over here, I would like to say that the first thing which you need to do is, if your case is microbiologically confirmed, then the diagnosis is always there. But the problem comes for clinically diagnosed. That means those patients who are clinically diagnosed, as there can be a over reliance on the chest X-rays, always keep in mind that it may not be TB, and always check for the DST reports. The DST reports, they need to be from an accredited lab, and also keep in mind that the infection could be which mimics TB. It could be due to the NTM or MOT. Now, coming to the presence of comorbidities like HIV, uncontrolled diabetes, or superadded infections, they can also be one of the reasons of the usual or poor non-response or poor response. Then always check for the regimen. That means the treatment regimen is proper, the drug dosages, as well as the drugs which are being given. And the foremost thing is the compliance. Poor compliance is one of the most common cause of failure to a particular regimen. And also keep in mind that it could be a paradoxical upgrading response. That means, and this is because the host immunity improves. So, because of the better host immunity, we have heard this term for HIV, but the same term is also true for tuberculosis. When you start ATT, a patient starts to improve, the nutrition part starts to improve, so the body starts to have a good immune response, and your lesions, they may start to increase. The child may start to have a high grade fever. But what we need to, and now the two things which need to be kept in mind, that it could be a it could be. So the two things which need to be differentiated is either it is DRTB or it is a PER. And the only criteria which can differentiate is that you have to rule out the microbiological, you have to send all the tests for microbiological confirmation, send the tests, that is CBNAT, the cultures, as well as the first and second line LPS, the tests which are available. Also send HIV and blood sugar. And if by chance none of these tests comes positive, so always remember three things in mind, that either it is non-TB, because the child a lymph node or something, if there is there and it is not improving, it could be a lymphoma. So always keep in mind for those patients who have no microbiological confirmation, that it could be non-TB or it could be PER. And finally, as we have discussed, it could be a probable drug resistance. So what to do? Over here, the most important thing is, if the DST cannot be determined, take the DST of the source, because that means if it is determined, then obviously start as per the DST. If it is drug sensitive, then you have to restart the drug sensitive regimen. But and if it is DRTB, or RR or MDR, then you have to start the DRTB regimen. But in those situations where the microbiological confirmation is not there, then always keep those three things in mind, which we have already discussed, and take the detailed history of the source, the contact. Because what we tend to miss is that there could be a family source, or a source like in the case of the child, it could be a school teacher. So we have to keep all those things in mind. And this is the new algorithm, which is now the integrated algorithm. That means if you have the drug sensitive, then obviously we start the DSTB regimen. For INH, we have a separate regimen along with its modifications. I won't be going into the details, but for our children less than 14 years, if they're eligible for the shorter MDR TB regimen, as we have seen, this case was not eligible for the shorter MDR TB regimen. It should have been given the longer all oral, or the regimen depending upon the age, which I'll be discussing. But if the child is more than 14, next, If the child is more than 14, now the program has started the 6 to 9 months of BPAL-M regimen. Next. So finally, for children less than 14, we have the drug sensitive, we have the INH monoresistant, and depending upon the severity criteria for DRTB, if it is non-severe, next, if it is non-severe, as defined by the criteria of non-severe, we have already discussed, that means intrathoracic smear and or culture negative, it could be NAT positive, uh, but the lesion should not be more than one lobe, no cavities, uncomplicated pleural effusion. If they are intrathoracic lymph node, they should not be causing any obstruction. And for extrapulmonary, only peripheral lymphadenopathy is eligible for non-severe TB. So non-severe TB, non-severe MDR TB or RR TB, the child is eligible for the shorter MDR TB regimen. And the depending upon the severity, if it is severe kind of severity criteria, disseminated TB or pre-XDR and XDR TB, then the child has to be given the longer all oral regimen depending upon the age of the child. Next. So the present status is, the WHO has recommended in the 2022 guidelines that bedaquiline and delaminate can be given to all children of all ages. But under our program, we are still following the safety, because the data for the TMC 201, that still is deficient on the data. They have not shared the data for children less than 5 years of age. So to keep that in mind, our anti group, we have taken a consolidated decision that bedaquiline will be given to children who are more than 5 and 15 kg, while delaminate safety data is available for children of all ages. So we are giving to all ages, but the weight has to be more than 10 kg. So whenever there is a child who is more than 5 and 15 kg, this child is eligible for bedaquiline based shorter as well as longer MDR-TB regimen. But for those children who are less than 5 years of age, but their weight is more than 10 kg, so over here you can give the delaminate based all oral longer regimen and injectable based shorter regimen. And for children who are less than 10 kg, so we cannot give delaminate even in them. So there we just have only one option right now, but we are working on this as a program. And now coming to the child friendly formulation next, you need to know that all the child friendly formulations are available under the program. I want to tell this house, we have the bedaquiline 20 milligram dispersible tablets scored, the delaminate 25 milligram dispersible tablets scored, and all the other drugs which are available as child-friendly formulations. Next. But mind you, even if they are not available, there is an availability issue. Studies have shown that the crushed tablets of adults, the non-dispersible, they have a good bioavailability, both for bedaquiline as well as delaminate. So you don't need to worry about that. Now coming to the relative contraindications, we know bedaquiline has to be used with great caution whenever you have site 3, 4, A4 inducers or inhibitors, as well as, there are some myoinhibitors or antidepressant, tricyclics, etc. And for severe anemia, bone marrow depression, thrombocytopenia, that is one of the relative contraindications. Whenever there is severe anemia, that means less than 8, despite your giving blood transfusions, hemoglobin is not picking up, and your TLC is less than 1000 and 75 less than 75,000 platelet count. So these are the relative contraindications, but that does not mean that you cannot start. You need to keep a good watch, and if it dips on further, despite your management, then obviously you need to withdraw that drug. And same is true for the hepatic as well as the renal function. Linezolid has, only 3 and 4. 3, linezolid usually, the myosuppression comes within the first 4 weeks, but the peripheral neuropathy develops a bit later on. That is the 3rd, 4th month that you need to take care. and the child would present with pains, needles, pricks. But if this pain, etc., it increases more at night, and the child has difficulty in walking, or these are the criteria where that means it is developed into grade 3 or 4. Next. So final, this is the last thing, because over here in our child, our child had cardiotoxicity. So mind you, whenever there is a cardiotoxicity, because the safe zone is 450 for males, 470 for females. But when we start these cardiotoxic drugs, because in the longer MDR TB regimens, we have, the 4 drugs which are cardiotoxic. That is bedaquiline, fluoroquinolones, clofazimine, as well as delaminate. So, first thing, if the QTC Friedrichia goes above, 480, as happened in this case, check for the electrolytes. If the electrolytes are normal, then you continue. But if the electrolytes are deranged, then you need to stop these drugs, as was done in this case. And then after the electrolyte correction, then you have to reintroduce these drugs every third day, keeping daily ECG monitoring. And the order in which the drugs have to be introduced, that is the last important thing, need to be kept in mind. Bedaquiline first, followed by fluoroquinolones, followed by clofazimine, because clofazimine is more dangerous than bedaquiline for cardiotoxicity. And finally, because data still is lacking for delaminate, so the last drug to be introduced is delaminate. So I think over here I'd like to end my talk. I don't think, yeah, this I've already discussed, so we don't need to. So this was in nutshell, I've taken you through the whole journey of uh, how to go about a patient who comes to your OPD as a new case. That means history of less than 1 month of ATT, or a case who is taken ATT more than 1 month. So how do we go about, and how do we, because majority of children, they you may not have a microbiologically confirmation. That means it's a clinically diagnosed case. So in a clinically diagnosed case, always keep 3 things in mind. That means number one, it may not be TB, or it could be MOT, or it could be, you started with the treatment, and still the patient is not improving. It could be, TB iris, or a probable MDR. So with this, I would now like to end over here. And if there are any questions, because I think I've gone in great detail, so I don't think there would be any questions.
Dr. Jennifer has joined.
So Dr. Jennifer, next please. So we are lucky this time. We have,
I would like to reiterate the programmatic concerns.
yes, please.
One, early diagnosis is important. So this child
Yes.
was missed.
Yeah.
Child was missed when the grandfather was unwell. First, I don't think the grandfather got the due treatment, and he continued to suffer with hemoptysis as the history was shared by your team.
Yes,
One,
please.
that should have been taken care. Two, the family should have been screened right there and then when the first
Yeah.
time the patient was diagnosed.
Yes.
Especially when there were small children. And if you remember, small children for ages, we have always screened in a family with TB. We have given them TPT after screening, after ensuring no active TB. That has been the practice for years, and why we miss them now is not obviously not being the programmatic guidelines are not being followed.
Yes.
Two, even with this case, you took care that the family was screened, but possibly the peripheral level where Palwal, you said the child was diagnosed, the family may not have been screened then. Only information we got was the older 2 brothers are healthy. There is no information whether their x-rays were done, there is whether they were physically examined or not. So all these things are bare essentials. Treatment, of course, you have discussed in great detail that, of course, the first initiation was wrong. And the other things you've talked about thoroughly. I am worried about people not ensuring, screening of the family and not giving TPT. While there is adequate TPT available all over the country, all states have surplus amounts of TPT and they're not utilizing it. They should be utilizing it, but after ensuring no active TB. So no fluoroquinolone resistance, Dr. Meena was stressing. I would say first, this has to be hammered in all program staff that they have to rule out active TB. Very, very effectively, they have to rule out active TB. And that has to be the first thing they should do, because if there is active TB and we can pick it up early in vulnerable population, as it is, we are saying there may be asymptomatic TB. So one should not just go by symptoms. Vulnerable population, there can be a small child ill and can have old parents, people who had TB in the past, smokers, alcoholics, diabetics, HIV, and of course the other vulnerables. That those we anyway can expect asymptomatic clinical TB or subclinical TB. In either case, their examination is very, very paramount to us, and that is what our 100-day campaign is also about, to screen all these high-risk population for asymptomatic clinical or subclinical TB, which is not being done in the field as of now, which should be done. Symptoms, it should not only be 4S to look for pulmonary TB, we should be looking for 10S to include symptoms for extrapulmonary TB, which again is a message I'm trying to give as wide as we can spread it to our even the last mile, our ASHA workers. We are trying to train them to look for 10 symptoms so we do not miss an extrapulmonary TB, because a layman may not be aware what can be the symptoms of extrapulmonary TB. Then going on to the Nikshay Poshan Yojana and Nikshay Mitras, I would again urge everybody, you, Dr. Sangeeta, mentioned that once the nutrition gets in, the patient recovers. It is such an important component of recovery from TB. The due nutrition has to be given. We are supporting, the government is supporting with the NPY, direct benefit transfer. All of you are aware the sum has been increased from 500 to 1,000 per month. So all that benefit should get to the patient, which will only happen if the Nikshay notification happens. So all that has to be done. In addition, Nikshay Mitra baskets have to be given to the family, where again the state's role comes in. And of course, I've already talked about the TPT. I think I'll finish now. We can have hear from Dr. Furan. Thank you.
So over to you, Jen, for the evidence which is available for these MDR TB regimens to be used in children.
Great. Thank you so much, Dr. Sharma, and thank you everyone for all the work that you're doing and for inviting me to join you this morning. Dr. Sharma is very kind to me, but I've been a pediatric TB doctor for more than 30 years, working on drug-resistant TB. And this afternoon, in your time, this morning, my time, I just wanted to share with you some updates to the WHO guidelines and to specifically talk about their application to children and adolescents. I think it's a very exciting time in pediatric drug-resistant TB, particularly with the options for all oral regimens for children. You know, delaminid has been safely used in children of all weight bands, including neonates, and there's more than a decade of experience. So I hope that India will rapidly start allowing the use of this drug in children under 10 kilograms, because the injectable containing regimens are really painful and dangerous for children. And there's also much more data now on bedaquiline in all ages. But I want to talk about the recent WHO updates that came out with a rapid communication in August of 2024. And the full guidance will be out early next year. And then to talk about the studies that went into supporting these recommendations. In the past, when WHO recommendations came out, it used to be based on expert opinion or very low quality data. But for the first time really in drug-resistant TB, we have data from high quality multi-country randomized controlled trials, including some trials that recruited patients and participants from India, which I know is always a big barrier to getting new regimens introduced in India. So the studies I'm going to present did include participants from India. And I want to talk about what this means for children and adolescents with drug-resistant TB. I think, as Dr. Ravashi was saying, the key with children is always screening, early diagnosis. They do better when we find them earlier. So just keeping that point in mind. But in 2024 of this year, August, the WHO released a rapid communication that reviewed data from 2 trials. The first was the Beat Tuberculosis trial, and the other was the End TB trial. And based on these 2 trials, they recommend an additional 4 all oral shorter regimens. So these are regimens lasting for 6 to 9 months, and that do not contain injectable agents, and that are actually better than the injectable containing shorter regimen, which has 7 drugs. These regimens have either 4 or 5 drugs, so that's great. One key thing, though, is that they did not compare these regimens to the BPALM regimen or to each other in terms of efficacy. So when you think about the many all oral shorter regimens that are now options for people, none of the studies compared them to each other. And then finally, the rapid communication from the WHO, it did not change or the grouping vacation. 2018, the WHO came out with the Group A, Group B, and Group C drugs. That has not been reviewed in almost 6 years. So it's just important to keep that in mind. So the first recommendation is that the WHO suggests the use of a 6-month treatment regimen containing bedaquiline, delamanid, linezolid, levofloxacin, and clofazimine in all MDR rifampicin-resistant TB patients with or without fluoroquinolone resistance. And the available evidence included children, adolescents, pregnant and breastfeeding women. And so the WHO specifically flags this regimen in those populations. And then the second recommendation was that the WHO suggests using 9-month all oral regimens, and there are 3 of them. One consisting of bedaquiline, linezolid, moxifloxacin, and pyrazinamide. One consisting of bedaquiline, linezolid, levofloxacin, clofazimine, and pyrazinamide, and one containing bedaquiline, delamanid, linezolid, levofloxacin, and pyrazinamide. And they recommend these over the standard of care longer regimens. They also suggest using the one that contains only 4 drugs over the other 2. So we'll talk about the data that went into these studies. Sorry, my slides are a little out of order. So the first thing that I wanted to talk about is the MD TB trial. And the reason I want to talk about this trial is because it did recruit participants from India. And so I think this can really help you in the hurdles you often face in India about having to redo studies that have already been done, but in Indian populations. So this was a really interesting trial. It included multiple countries. It was a non-inferiority trial, and it used what's called adaptive randomization to assess multiple 9-month regimens. So the goal in this study was not to find the best regimen, but to find as many possible regimens as they could that were non-inferior to the standard of care. So in a study like this, they randomize the patients, and after a certain number of patients have been randomized, they compare each of the study regimens to the standard of care, and regimens that are performing well carry forward, and regimens that are not performing well get dropped out. So you can, this is a way to recruit a study more quickly, and is a study design that's often used in cancer and other non-infectious diseases. So all of the regimens in NTB contained pyrazinamide, and the other regimens used very differing combinations of either bedaquiline or delamanid or linezolid or levofloxacin or moxifloxacin or clofazimine. Slide just reviews the adaptive randomization and talks about that the goal was not to find the best regimen, but to find as many inferior regimen possible. One key point is that every regimen was compared to the standard of care, and the regimens were not compared to each other. Okay, so this is what the study schema looked like. The 5 regimens that are in there were used for 9 months, and they were compared to the 18-month standard of care that was all oral and did include many of the same drugs. So if you were randomized to one of the shorter regimens, you got 9 months of therapy and then you were followed up. If you were in the control regimen, you got 18 months of therapy, and then everyone was assessed at both week 73 and week 104. And the study looked at both efficacy and safety. The efficacy endpoint was a composite endpoint that included multiple outcomes, and then the safety was any grade 3 or 4 adverse event. And this is just looking at the efficacy endpoint for each of the regimens. And you can see the standard of care arm had an 80.7% treatment success rate. And then all of the regimens seemed to perform reasonably well. But when the analysis was done, NTB regimen 1, which was bedaquiline, linezolid, moxie, and pyrazinamide, NTB regimen 2, which was bedaquiline, linezolid, levo, clofazimine, and pyrazinamide, and NTB regimen 3, which was bedaquiline, delamanid, levo, linezolid, and pyrazinamide. They were all found to be non-inferior to the standard of care. NTB regimen 4 was not. So this was a regimen of delamanid, linezolid, levofloxacin, clofazimine, and pyrazinamide. And NTB regimen 5 was only found to be non-inferior in the modified intention to treat analysis. So that was delamanid, moxifloxacin, clofazimine, and pyrazinamide. So the first 3 regimens met all the criteria for non-inferiority, and those are the 3 regimens that are now recommended by the World Health Organization. I would point out they all contain drugs that have been safely used in children of all ages and all weight bands, and they're all available, as Dr. Sharma mentioned, in pediatric formulations. So the authors concluded that we now have 3 new options that we can offer for people, that the results were excellent in all populations. So regardless of disease severity or comorbidities, the outcomes were the same. And that this data and this study is very high quality evidence, and it included participants from India. In terms of safety, in the control arm, the standard of care arm, there were more drugs that were stopped due to adverse events, and this was most commonly seen with pyrazinamide. But the 3 arms that were deemed non-inferior were also found to be safer. And in this study, they actually used a dose reduction strategy for linezolid, and it was a planned dose reduction at week 16, where they cut the dose in half, and that may have contributed to the safety. So the other trial I want to talk about is the Beat Tuberculosis trial. So this was a trial that was done only in South Africa, so keep that in mind. But it was a randomized controlled non-inferiority trial that compared the all-oral 9-month regimen that they use in South Africa with a 6-month regimen that consisted of bedaquiline, delamanid, clofazimine, levofloxacin, and linezolid. And then if there was DST available for the fluoroquinolone, either for the patient themselves or for the contact, if quinolone resistance was not detected, then clofazimine was dropped out of the regimen. And if quinolone resistance was detected, clofazimine was continued. I would point out that there were very few people who ended up having quinolone resistance in this trial. So just keep that in mind. The study enrolled children, pregnant people, and people who were breastfeeding. And they also used a composite endpoint for efficacy, where they defined unsuccessful treatment as treatment failure due to lack of conversion, bacteriologic reversion, or stopping 2 or more drugs due to adverse events, death, lost to follow-up, or not evaluated. And this was the same composite endpoint that was used in the Practical trial and the NTB trial. And then they used the same safety endpoint, which is any grade 3 or 4 adverse event. As I mentioned, they included people from a wide spectrum, although the study was only done in South Africa. And then, I'm sorry, this is where my slides are out of order, forgive me. So the study enrolled 374 participants, and the interim analysis showed that the shorter regimen, the 6-month regimen, was non-inferior to the 9-month standard of care. And that most of the endpoints were due to discontinuing drugs in the longer regimen arm. And this publication, we're waiting for it to come out. The NTB trial that I presented earlier, that's been accepted in the New England Journal of Medicine and should be released either later this year or early next year. And then the last thing I want to mention, so most of these studies are done in people who have TB that does not have fluoroquinolone resistance, but the NTB trial actually had a study called the NTBQ trial that recruited participants whose strains of TB had fluoroquinolone resistance. So this is the only randomized controlled trial that is done among people whose strains of TB have quinolone resistance. And the results of this trial were presented at the Union meeting in Bali. So they compared a 6 to 9 month regimen of of bedaquiline, linezolid, delamanid, and clofazimine with an individualized longer regimen for people whose TB had quinolone resistance. And the outcomes were excellent in both arms, but overall the trial did not meet non-inferiority criteria. But the study found that if you use a definition of non-severe disease that Dr. Sharma mentioned, the treatment success rate was 93%. So the WHO is going to be reviewing these data, but hopefully there'll be a recommendation early next year for people with quinolone resistance who have non-severe disease to use a 4-drug regimen of bedaquiline, linezolid, delamanid, and clofazimine. This really does raise the question, though, from the BEAT tuberculosis trial, where they had a very small number of people with quinolone resistance and concluded that you could use the 4-drug all-oral regimen. There is some caution now that we have, and we really say that you really should only use that regimen or even the BPAL regimen in patients who have non-severe disease. So just keep that in mind. So as I mentioned, both trials included children down to the ages of 6 years and pregnant women and people, but the drugs that were used in both of these studies have all been used in children of all ages and all weight bands. And there's extensive experience, particularly with delamanid in children of all weight bands. And they also either enrolled pregnant women or allowed women who became pregnant to stay in the study. And so unlike the BPALM regimen, where we can't use pertomanid, right, in children or in pregnant people, these regimens, the BEAT tuberculosis regimen and the END-TB regimens, can be used in all populations. So this is very exciting. And I think could be something that your program reviews very quickly to get rid of those injectables in children. It's really heartbreaking that India still injects children, especially the youngest children, since that's been stopped in most countries for more than a decade. So as we mentioned earlier, the diagnosis of drug-resistant TB in children and adolescents really remains the major problem, and you all reviewed that very carefully in the prior case, so I won't go into that in any more detail. We're hoping to be able to start using pertomanid in younger children and adolescents soon. The reason that was not done is because pertomanid was shown to cause testicular toxicity in animals. The human studies have been done and have been submitted to regulatory authorities. So we hope that we'll be able to start using pertomanid in adolescents and younger children. We're just not sure how to dose pertomanid yet in those age ranges. But as Dr. Sharma mentioned, adolescents over the age of 14 can indeed receive BPALM. So just a final couple of points in terms of the most toxic drug for children. If you're injecting children, if you're still using amikacin, the injectable agents are by far the most toxic in children. But if you've moved away from using injectables, which everybody should be doing now, India is really one of the few countries that still uses injectables in children, and your program has so many achievements. It's hard to see that one not be achieved yet. But linezolid is really the most toxic all-oral drug for children, and it can be particularly difficult in very young children to detect some of the toxicity. So there's been an interest in looking at linezolid-free regimens, particularly in children with non-severe disease. When we talk about all these nice shorter all-oral regimens, it's key to remember that with meningitis and osteoarticular TB, even if you have drug-susceptible TB, you still need 12 months of therapy. So children with osteoarticular TB or TB meningitis do not qualify for shorter regimens. They can get all-oral regimens, but they can't get shorter regimens. And then again, just to mention child-friendly formulations, which really make it a lot easier for children and their caregivers. Dr. Urvashi talked about prevention, and I'm so glad this came up because we now do have the option for preventive therapy for drug-resistant TB. And in fact, the 2 papers that led to this recommendation from the WHO were published in the New England Journal of Medicine yesterday. the recommendation for preventive therapy in children and adolescents is based on 2 randomized controlled trials called TB Champ and VQuin. They were high quality trials, and they did look at household contacts of all ages. So this is something we should be rolling out quickly. And then I want to mention the Rations trial, which was in drug susceptible TB, but really applies in drug resistant TB. It's a beautiful study, one of the best studies ever done in TB that came out of India, looking at nutritional support for household contacts. And providing nutritional support to see how it impacts the development of incident TB. And the study found that households that got nutritional support had a much lower rate of incident TB compared to households where only the person with TB got nutritional support, and that the strength of this reduction was on par with many drugs. So we should be giving nutritional support not just to people with TB, but to their household contacts. And this was a beautiful study done in India. And that there's a need for counseling and support for families and improved access to chest X-ray. So I just want to stop there. I want to thank my colleagues at the NTB trial for giving me access to their slides, and then Dr. Francesca Conradi from the Beat Tuberculosis trial for providing these slides. I want to thank all of you for the incredible work that you do every day for children with TB, and to congratulate you on this great session. And hopefully we'll see these all oral shorter regimens that are now recommended by the WHO moving very quickly into the pediatric population in India. Thank you.
Thank you, Jen. It was a wonderful journey through, the data which is available presently, and to give you an update, because,
Sangeeta,
I mean,
I had a question for Dr. Jennifer, please, if I may.
yes, please, yes.
So of these studies that she so beautifully covered, I only wanted to highlight that a few of the regimen do not have adequate data, and the recommendation by WHO is also conditional and weak evidence. Also, I'd like to highlight some of the regimen have very high recurrences and relapses. So I don't think, in fact, in our expert committee, we discussed all these regimen, and all the experts were not convinced of the evidence available in the publications. We would like to be more convinced, especially, we do not want to adopt a regimen where recurrences may happen and the program may miss them. We would await more evidence to accumulate before we make our adoption. And when we talk of any WHO recommendation, I think it is pertinent that we also highlight the recommendation and the evidence, whether it is a strong recommendation or a weak recommendation, whether the evidence is strong or weak. I think that should also be brought in whenever we are referring to any WHO recommendation.
Thank you, Dr. Urvashi. I just want to, so first of all, there actually were not high rates of relapses in these studies or recurrences that in these trials, which actually were based on randomized controlled trial data. So the regimen that you're currently using in India is not based on any study that's ever been done. So there's no randomized controlled trial data to support the regimens that are currently in use in India. And that the regimens that I just talked about were actually done
So I guess we could have a separate discussion on this.
We could, Dr. She, but correct what you're, because it isn't true. So these were randomized controlled trial data, so they're actually strong studies supporting them, and the rates of recurrence and relapse were under 3%. So I'm not sure.
PDLLC had 4.7% recurrence because we have looked at the raw data. We are aware of that, and the others also, of course, I didn't mean all had recurrences.
Few had this. So I think if we want to talk about data, that it's important that we share the actual data. So as I mentioned,
I would have appreciated if you put the recurrence data, which I didn't see it. But I guess we can have a separate discussion, a detailed discussion with Dr. Sangeeta and you and myself.
Yes, that would be great. Like I said, the publication will be coming out in the New England Journal of Medicine, and in the 3 NTB regimens that are recommended by the WHO, the recurrence rate was less than 3%. Thanks.
So, I think we have, as Dr. Urvashi has said, we, under the National TB Expert Group, we had a 2-day discussion regarding adopting these regimens. What is seriously lacking is the Jensen data for children less than 5 years of age, because they have given for 2 cohorts, that is 12 to 18 and 5 to 12. But less than 5 years of age, we are still waiting for Jensen company with their which is still lacking. And so under the program conditions, Dr. Jain detailed discussion, and as DGTB has clearly stated that we are a bit apprehensive in adopting these regimens at this present
Sangeeta, we
time.
wrote to the DCGI,
Exactly.
and the DCGI, for want of data, we have
Exactly.
written to him twice, but
Yeah.
that is not making progress.
Yes.
After the expert committee, we wrote to DCGI twice.
Yeah.
But for the want of data, the DCGI is not comfortable, So
Yeah.
what you said is right, that we need more data.
So we need more data. And Jen, just to a brief, a single line, even I was called by the WHO in this union conference at Bali to present the data which of the trial, which the randomized control trial, which I am conducting over here in our unit. So we have the 3 cohorts which are being examined, that is the longer BDQ or the delaminate based regimen, along with the shorter, the combined regimen, which contains both BDQ and delaminate. So, I mean, that's also very encouraging data of a cohort size of 73 per cohort in the 3 cohorts. So let's see what finally emerges out. And so I think we have come finally to the end of a session which was quite useful, a good learning experience even for me. I mean, what you shared with us, Jen, was um, uh, um, up-to-date knowledge of what has happened, but our concerns still remain, as highlighted by DDGTB. So we are still waiting for more data to emerge. Because the volume of, because we are not so comfortable in the monitoring part. These studies, monitoring is good. Like for my own trial, the monitoring is good because the children, they come and we are able to monitor them every month. But in the field conditions, sometimes such things don't happen. So
Sangeeta, even post-treatment for you, the monitoring may also become difficult.
Exactly. And also the follow-up. So, we are still waiting, and I think we are still going slow and steady wins the race, I mean. That's the strategy which my country adopts, and I mean, we are quite comfortable with this, although we do realize that children, less than 10 kg, we are still giving them injectables, but the proportion of those children are very less. And the overall safety data, as it will emerge, I totally assure you on behalf of my DDGTB that our country, India, would be the first to take up these regimens on a war footing, as we have done for the BPAL M. Now, the BPAL M has been rolled in our country, and we have also rolled the intensified national TB elimination program, in our 400 plus districts across our country. So and we have also enrolled the pathodetect test, and then the expert XDR for diagnosis. And for the regimens, as I said, we are looking for bidaclin delaminate for all ages. BPAL M has been for more than 14, we are already through. And so with this note, now I would like to thank each one of you and give
So,
to
Dr.
my
Sangeeta, just if I may, for the BPAL M, we
yes,
had an in-country evidence supporting it.
yes,
Then we took it forward, and again
yeah,
we've taken BPAL M and adding M to FQ resistant patients also,
yes,
as was shown in. So few of these studies Dr. Jennifer showed were very good studies,
yes,
as was NTB And so we are adding Moxie to even FQ resistant because there is evidence to show there are no recurrences in this group.
Yeah,
As compared to BPAL, where we may have to sometimes stop or lower the dose of linezolid and we'll be left with only bedaquiline predominant. And we are not ready to lose these two drugs to resistance in our country. So we are again, treading carefully. We don't want to, encounter any of these issues in the long run. And it was it was not easy bringing this in, and we have the drugs available with us now, and we're rolling it out. Thank you.
So over to Dr. Saroj.
So with this insightful talk by Dr. Furin, we have come to the end to today's clinic, and I would request Dr. Ashok Bhardwaj sir, who is chairperson of National Task Force, to deliver the closing remark for today's session. So over to you, sir.
Thank you, Suraj. It was a wonderful discussion today. So wonderful discussion, the case discussion. So for case, I would like to focus that we should follow the program guidelines. We should in no way deviate from these guidelines. Otherwise, we will miss somewhere, and the benefit will not be to the patient, not converted to the patient. So then, very thankful to Dr. Sangeeta for wonderful detailed discussion on her part. And of course, Urushi is always excellent. So, Jennifer, the newer trials. So, besides this, I want to reiterate that as Dr. Urushi also pointed, the country has gone for 100 days campaign for accelerating, eliminating TB from the country. So, I will call upon all the participants and to their friends and to their colleagues that we should support in this 100 days campaign. We have to have more case detection and we have to reduce the number of deaths. And the last, which Urushi reiterated, we have to effectively do progress toward TB preventive treatment. Unless TB preventive treatment is not rolled out in a big manner, we will not be able to end TB from the country. So thank you very much. Thank you all the participants. So at one time it touched 96. So I was waiting for the century, but hopefully next time we will have more than 100 people. So thank you very much.
Yeah, sir, your messages are totally clear. And this is precisely the reason we came up with this case. How, simple things which were missed outside, and the child was referred to us. So we need to disseminate the information and we need to have more of such training programs as we are conducting this pediatric TB eco clinic. We are also having the difficult to treat adult TB clinic. So as NITRD being a national center of excellence and my department being a national center of excellence for pediatric DRTB, we got this case referred, from outside when the child was moribund. The child came to us, and by that time, the child had already bilateral extensive pre-XDR TB. So this case we discussed today to bring out the deficiencies, in the program implementation at the field level. So we need to increase the awareness of all our clinician colleagues who are practicing at the field level, and that is precisely the motive of this eco session. So with these words, I would like to thank each one of you to be a part of our pediatric eco, and we have been joined by quite a few pediatricians today also for the first time, and I'm sure this scientific session would have benefited a lot of you. Thank you, each one of you, for joining us.
Thank you.
Thank you, ma'am. So with this, we end today's clinic. Our next eco clinic session will be on 21st of January, and the case will be presented by AIMS Delhi team, the Department of Pediatrics. So thank you once again. Thank you everyone for joining us and having the patience to visit the clinic.
Thank you all.